Dear colleagues, my name is Sven Poli from Tübingen University. I am stroke physician and the co-PI of the ATTICUS randomized trial that stands for Apixaban for treatment of embolic stroke of undetermined source. The ATTICUS investigator-initiated trial has been supported by Bristol-Myers Squibb Pfizer Alliance. The background is that optimal therapy of embolic stroke of undetermined source is not yet established, and atrial fibrillation is supposed to be a major cause of ESUS. Two large randomized control trials, the RESPECT and NAVIGATE ESUS trials, have been negative, not being able to show beneficial effects of direct oral anticoagulants compared to aspirin. Our hypothesis was that Apixaban compared to aspirin may reduce the incidence of new ischemic lesions on 12 months follow-up MRI in an enriched ESUS population with additional risk factors for cardiac thromboembolism, including clinical, echocardiographic, and electrocardiographic AF prediction factors. The objectives were to determine efficacy and safety of Apixaban in this enriched ESUS population, and mandatory continuous AF monitoring in all patients should provide insights in prevalence of AF, its burden, association with recurrent ischemic strokes and new ischemic lesions. The study design was prospective, randomized, active controlled, open label, and blinded endpoint assessment. 15 German centers participated in this phase 3 trial. Patients with ESUS, and as I said, these additional cardiac thromboembolic risk factors on echocardiography or electrocardiogram or clinical plus mandatory continuous AF monitoring were enrolled. They were randomized 1-to-1 to either aspirin 100 milligrams per day or Apixaban full dose 5 milligram. Study treatment should be initiated in between 3 and 28 days, 14 days in major strokes, and we had the final outcome follow-up visit at 12 months, including the MRI for detection of new ischemic lesions, the primary endpoint. Secondary endpoint focused on efficacy and safety assessment, and exploratory endpoints were focusing on AF burden associations. We had an adaptive statistical design with an interim analysis after inclusion of 200 patients which had their 12 months follow-up. On the basis of the interim analysis that included 165 evaluable patients, the trial was terminated due to fertility in August 2020. There were no safety issues, and the DSMB recommended accordingly the continuation of the study visits and the therapy according to the protocol. The final analysis includes 352 patients. Baseline characteristics were well balanced between the groups. Patients were a little older than in the two larger randomized controlled trials, RESPECT and NAVIGATE, 3 to 4 years. More females were included, so it's 50%. We had more risk factors, 10% more hypertension, 5% more diabetes, and the time from index stroke to randomization in median was only 8 days compared to 46 days in RESPECT and 38 days in NAVIGATE. 325 patients were available for the primary endpoint analysis, which was neutral. So there was 13.6% of patients had a new or more new ischemic lesions on 12-month follow-up, and 16% of the aspirin-treated patients. P-value was 0.57. Most of the patients had continuous AF monitoring with the implantable loop recorder, a smaller fraction with the intermittent AF detection monitoring physio-mem from GT-MED. AF detection was in 23% in the Apixaban arm and 28% in the aspirin arm. There was no difference regarding these two groups, AF detection or no AF detection, with regard to the primary endpoint. Keep in mind that all patients on aspirin, so 28%, were switched to Apixaban after AF detection. Clinical endpoints were equally not significant. Time to recurrent stroke, 5% in the Apixaban arm, 5.7% in the aspirin arm, and other systemic embolism, pulmonary embolism, myocardial infarction, all-cause death, and a composite endpoint, including all of them, were neutral. Serious adverse events were similarly same in both groups, around 30% in both arms. Bleeding complications were low regarding major and clinically relevant non-major bleed. There was no intracranial hemorrhage, and there was a difference only between the two arms with regard to minor bleeds. However, looking at any bleeds, there was no significant difference. Subgroup analysis for the primary endpoint again showed no significant difference. However, the odds ratio was in most cases below 1, and values below 1 favored Apixaban. Similar to the RESPECT study, we have found that age above 75 years that there was a trend for better outcome. In summary, ATTICUS was the first trial testing the concept of direct oral anticoagulation versus aspirin in an enriched ESUS population with additional risk factors for cardiac thromboembolism, including clinical echocardiographic and electrocardiographic AF predicting factors. Apixaban was not superior to aspirin, with switch to Apixaban in case of AF detection by mandatory cardiac monitoring in preventing new ischemic lesions during 12 months of follow-up. AF is common in this enriched ESUS population, 28%, and early initiation of Apixaban after ESUS in median 8 days appeared safe in this study, with only the number of minor bleeds being increased compared to aspirin. The conclusion is that mandatory cardiac monitoring, vessel imaging, and MRI in all ATTICUS patients will help to better understand this complex condition. These are included in a lot of pre-specified analyses which will follow. And the final conclusion is that ESUS is not dead, but still poorly understood. Thank you.